Ready, Sam.
Good evening, everyone. Thank you to each and every one of you for being here with us today. Today is 23rd March 2022. Let's go back to 1986 when Dr. G. Burt Holmes, former president of the American Optometric Association, took ownership of the International Optometry and Optical League and transformed it into a dynamic organization committee committed to improving vision care standards all around the world. Since then, World Optometry Day is celebrated on 23rd of March of every year all over the world. In this occasion, we are here to celebrate this day by sharing our knowledge and experiences. Me and Muhammad Oli will host this scientific event. I just want to give some brief introduction about Muhammad Oli. Actually, he completed Bachelor in Optometry in 2009 and completed his Master and Fellowship from Educational Eye Institute. He has done MBA in Healthcare Management and Administration. He was Administrator and HOD Optometry Department in Krishna Eye Center and Advanced Eye Center Eye Hospital, Mumbai. He is a co-founder and director of Binocular Vision Therapy. And he is also moderator and co-host of this scientific session. So let's start our journey today. So we'll start with our first topic of history taking in ophthalmic patient by Mr. Ujjwal Kumar Roy. Mr. Ujjwal is Mr. Ujjwal completed a Bachelor in Optometry Mr. Ujjwal Kumar completed Bachelor in Optometry and currently working in Moorfield Eye Hospital, Abu Dhabi. So, Mr. Ujjwal, you can start now your presentation.
Yeah,
I'll share the screen.
First of all, happy optometry to all of you, and thank you for giving me this opportunity actually. And because the way you called yesterday, I could not say no. So I thought, okay, I was not prepared. So the presentation I had, I just came up with that. Can you please share the presentation?
Yeah, I'll share the screen. Okay, start.
Yeah.
Make it slideshow.
Be better. Okay, so though history taking is nothing new, or we have been in the process every day and day out, the reason why I have taken this topic is, sometimes we need a little bit of brush up kind of things, and in our daily basis we don't come across all the kind of different kind of patients on an average and daily basis for most of us. So it'll always be better to go back and just get the glimpse of the things that we studied before, so that we just don't miss out the track, and we keep the same pace that we learned, and then it helps us in our diagnosis and different parameters. So can you go to the next slide, please? I think it's not in the...
So now, while you are sharing your screen, please share the first option called screen. We are not getting your screen. I've just stopped sharing. Okay. So click on share screen. And the first top left is called screen.
Screen where?
Top left.
Where you had shared.
Top left, okay. Left. Yes, yes.
Click on that and share.
Now it's okay.
Now go to Power Presentation mode. Yeah. Now click on yes.
Okay.
Perfect.
So what we are going to get in this one is, like, we'll try to get some overview about the importance of the history taking and some major components of history taking, and then different kinds of patients that we encounter in our practice, whether we're in an optical shop or in private practice, in clinics, hospital. And this will also have, like, some aspect of the multidisciplinary aspect of the history taking. Next slide, please. Now, why the history taking is important? It helps us to understand the patient's need. When the patient comes to us, we don't have a clue initially like why the patient is here. So when we ask certain questions, it helps us to understand why the patient is here, and it also helps us to decide what are the necessary examinations might be needed, and it also helps us to expedite the things and focus in exactly like what we are looking for. Next slide, please. The other part of now, before coming to this usual composition, one more reason, or one that history taking is more important, which I missed, is like it also helps us to get the idea, like, how the visual impairment or visual condition or the ocular condition is impacting the person's day-to-day activities or daily life. So that is why if we get the history, we can help the patient better. Now, what are the main components of history is personal data, chief complaint, past ocular history and past medical history, drug related histories, then history of any surgery, trauma, etc., any family history, social history, etc. Now we'll go in between, like in bits of pieces, and then we'll discuss in detail. Next slide, please. Now, yes. Now, the first part was the personal history. When we know in the personal history, main things comes is the name, age, and the gender. These things helps us to get some idea, like with the name helps in the rapport building. When you address all of us, we prefer to be called with our name properly, right? So the name, when we call a patient, to pronounce the name correctly as much possible. Especially being here, we can understand that there are certain names which might be difficult for a person to get it correctly, but in case we are doubtful, we can always verify with the patient, and it makes them comfortable. It makes them like, okay, you are trying to do something good in that way. So it helps in rapport building. And the age gives us some idea like what kind of conditions the person might be having. But most importantly, and the gender as well, like there are certain conditions which were more common in the female than the male. Some conditions are more common in the males than the females, like color blindness, etc. So that these things helps us to decide the path. Now in the chief complaint, there can be a few different variety of chief complaint. One is first and foremost, which is related to us, is the vision related. Whether the vision is blurred or decreased vision, or whether it's decreased for reading or distance, or any particular, say someone is having a computer vision difficulty, or any floaters, flashes kind of thing. So it can be vision related, it can be physical discomfort. When the person comes to you as a patient, he may have irritation, itching, redness, discharge coming out. So there can be two different kind of different kind of complaints that the patient may come in. So based on that, we need to ask, like for example, if the person is saying itching or irritation, so if there is any redness with that, if there is any watering, if any discharge, so what kind of discharge, if it's a whitish, it's a ropey discharge or watery discharge. So these things will help us how to proceed about. We'll discuss these things in detail in a bit. The other option is, say for example, in the chief complaint, especially for kids, this is very important. Sometimes the parents will come that suddenly they have noticed that the kid's eye is moving in or out, or there is a face turn or chin up, chin down kind of. So all these things they may come up with, or the nystagmus, the bubbly movement of eye. So they will come up to present like what is the status, if there is anything to be done. So in case of pediatric patient, the birth history is very important, because all of us, we know that ROP is a very serious thing to be taken into consideration. So whether the birth was premature or full term, what the mode of delivery, it was surgical or like or normal delivery or forceps delivery kind of, assisted delivery kind of, any complications during pregnancy or during delivery, that can be very important. But weight is very important. And then any incubation was done, if any oxygen has to be given just post delivery, so that can increase the chances of ROP. Or in the history of consanguinity, here especially in UAE it may be little tricky, or it may not be very easy to get the detail, or sometimes people may feel offended, but we need to be little more compassionate about that to get the consanguinity history, and sensitive as well. As far as that, then milestones and the family history. If there is any pre-existing conditions in the family, for example, any pre-existing squint any of the family members, or keratoconus, or any glaucoma, these kind of things. In case of squint patient, now the squint, it depends like what kind of deviation the person has. So we can ask like if the deviation is inside or outside, if like if the eyes are moving in or out, or if there is any constant deviation, or sometime it is straight, sometime it is deviated, or if it is more towards the end of the day, or any particular condition only when the person is sick. So if there is constant or intermittent kind of thing, so this is very important. If the deviation was noticed at birth, or it developed following a trauma or any condition, these things are very important. And any history of, in case of squint patient, we need to get if there is any squint surgery or done already. And family history or diplopia is also very important. The other common thing in the history part for the ptosis, where the parents, mostly it comes with the kids, or sometime in adults as well, like there will be a droopy lids. So droopy lid can be sudden onset, or it can be like since birth. So we need to be considering that portion, and sometime whether it is like age of onset. That's the reason that age of onset is very important, and at what age the patient is presenting to us is also should be taken into consideration. In case there is any physical component, like any tumor or anything which is pressing the lid down, or if any squint which is actually causing the droopy lid, this is very important. So whether any associated symptoms are there, if any chin position is there, what kind of vision status, if it is a verbal patient, we can ask like if the person can see clearly, or the vision is not very clear, or if the person needs to take a particular posture for vision quality. So these kind of related questions are very important, which will help us to get a proper idea like what kind of condition the person might have. Sometime based on the ptosis, there can be a significant amount of astigmatism, especially if it is a younger kid. That may be important to notice, so that we can avoid the chances of developing amblyopia. And that's why this is also very important. Now, especially this one part, the patients with headache. So headache is very generalized term like fever. It can be due to several causes. So it can be due to migraine, it can be due to eye related issues, it can be due to sinus, several other things. History is something which almost half of the time, or more than 60-70% of the time, you'll get to the conclusion, or it will lead you to the conclusion or diagnosis what kind of headache the person has, like based on region, whether it's a bow area or frontal area. That is more commonly for the refractive conditions. If it is one-sided, which is more common in migraine, whether it's a pricking or heaviness kind of headache or throbbing headache, the duration of the frequency, like when was the first time the person experienced the headache, and how frequent the headache is going on. This is very important. And also if the headache is more in morning or evening, what are the associated symptoms and signs? If the person is feeling like more headache is more when the stooping down or bending down, or if the headache is more with a visual task. So this can give us some idea, and based on the that we can decide what kind of headache it might be, if someone needs orthopedic evaluation, if someone needs any other particular focal approach. Then the refractive surgery patients. So there will be people with the they have already done the refractive surgery and then can present, or may just come to seek an idea like what are the refractive surgery options. So based on that, first things we need to do, the things which are very important for the refractive surgery, especially for the new patient, the lifestyle of the patient, and what kind of visual condition they have, if they're already using glasses and or contact lenses or both. So what is the visual outcome of that, or what's their expectation, and like how stable is the glasses, the contact lenses like prescription, and the present correction, if the visually they're comfortable or if they feel that it is changing. So these things are very important in case of refractive surgery patient. In refractive surgery patient, we also need to see another part is if there is any other injury, or if they had already taken some previous opinion, that can also give us some insight about the approach. Next slide, please. So no, sorry, the previous slide. I'll go with the next. Yeah. So for example, whether the refractive surgery, the person is looking for just a cosmetic purpose or just for freedom, or feels like with it's a heavy prescription and it is very difficult to manage without glasses, so just want to get some relief on that side. So these things are very important to note down, and it will also help the surgeon to decide or to explain properly what is the possibility. As an optometrist, what we can do is we can also get some insight, and sometime even they will be asking what is our take on that. So if we have an idea what's their lifestyle and what kind of condition they have, at least we, especially if we are practicing individually in the individual practice, or the people who are in optical shop, at least they can give some idea like this is the condition and this is what you can expect and this is the limitation. So this is why we need to know first the background, and then only we can guide them properly. And if there is any family history of any corneal conditions, corneal dystrophies or keratoconus, any other corneal related issues, these are very important, other retinal detachment, these things are very important that to note down. Next one, please. Next slide. And now this is the patient with trauma. When mostly the patient with trauma will be in the emergency, so we need to be a little quick, but we need to try to get as much information possible. So first and foremost thing is when that happened, which eye, how it happened, whether it's a blunt trauma or it's a penetrating trauma. That is very important, because based on that there are several other implications, or diagnosis, or procedural things will be different, or approach will be different. So whether there is any associated pain, or how is the vision, these things are very important. If it is a penetrating kind of injury, or even in some cases of blunt trauma, the instrument of injury, whether it's like if it is something that can, it's not penetrating but it scratches or there's bruises, so those things are very important. If it is incidental or accidental or intentional, sometimes there will be people like they will come up, like for example there are people who keeps on plucking the eyelashes, and then sometime mistakenly while plucking the eyelashes it goes in, and then uh, they touch the cornea and then they come up with some kind of injury. So these things are very important as well. And some lead conditions that can be inflicted with repetitive plucking of lashes. And if any primary care is given, or any previous history of trauma or surgery done to the same eye, these things are very important, which will help us to decide the approach. Now patients with glaucoma, mostly patients with glaucoma will have a familial history. There can be someone in the family, so we need to get the family history very properly in case of glaucoma. If we get the idea what kind of glaucoma the family member had and what kind of treatment was provided, that can help us or help us to plan the management more properly. As far as the approach from as an optometric point of view is concerned, we need to know like if it is already pre-diagnosed or just for the screening they have come, and what kind of relation the person has. So that is very important. And if there is already any medication or surgery done, that is also to be noted down. Next slide, please. So, yep, these are the common histories that usually we encounter, and hope this helped. Maybe next time we'll come with a better kind of presentation. These are some references for my slides. If any questions, I'll be happy to answer. Thank you.
Thank you, Mr. Ujjal, for that wonderful presentation, because this is very crucial part of any clinical practice. It starts from history taking and then goes on to a different stage. This will enlighten all of us. And if you have any question, we'll take after the next speaker. So after every two speakers, we'll have a panel discussion
Sure.
where Shona will introduce the panelist after the next talk. So our next speaker is Professor Dr. Sonia Nankani. She is one of the renowned ophthalmologists in the city of Mumbai. She did her graduation from post-graduation in ophthalmology from Kasturba Medical College, Mangalore. Post that, she did her cornea fellowship from L.V. Prasad Eye Institute. To give a little clinical history, she was one of the pioneers and first surgeon to do osteodonto prosthesis, the modified one in the city of Mumbai in way back 2008. So she has done numerous such corneal transplant in the end-stage corneal related refractive blindness. Apart from that, she headed many institutes for DNB ophthalmology as well as MS ophthalmology. And post that, in her clinical practice, she has special interest in pediatric ophthalmology as well as binocular vision disorders. Today, we wish to listen from her about how binocular vision disorders are becoming more frequent issues in today's clinical practice. It's like the topic in today's digital world is how digital eye strain becoming an pandemic today. So I would like to invite Professor Sonia Nankani for her presentation. Can you unmute yourself, ma'am, and share your presentation?
Thank you, Oli. And I must thank the entire organization for giving me this opportunity. And at the outset, I want to congratulate everybody on the Optometry Day. So let me share my screen now. Can everybody see that?
Perfect. Maybe the camera become too high, so we don't see your face properly.
Okay.
Yes, great, good to go.
Okay. So today we're going to talk on digital eye strain and has it become a pandemic? One sec. How do I go into, I'm not seeing how do I get into the slideshow?
It's already on. You press enter key and just it will give on to the.
Okay, it's not moving.
Not moving. Can you reshare once again? I've stopped sharing. So click on.
Okay.
And select maybe the option called screen. Right, and just press the enter key and see if it happens.
No.
No, it's not moving. Press escape button first. Escape.
Okay.
Okay. Now click on share screen.
Okay, I'm back here. Wait, share screen. Should
And
I go PowerPoint straight?
no, you
Slideshow?
can go to screen, the first one, top left, in that case.
Yeah.
And click on screen and click share.
Yeah.
Now if press the enter key and see if it is moving.
No.
No.
It doesn't.
So can you
See.
give me access? Give me access. Just approve.
Okay.
Perfect. You can see the screen, right?
Yeah, I can see the screen.
Okay. Do you see the next? No, it's not moving. So press the escape button once again.
Escape. Okay.
And on top, you have a new share.
Okay. It is just showing. Okay. Should we restart the whole thing?
No, click on share and don't select PowerPoint. You have to go top left, which says screen.
That's exactly what I've been sharing all along. That's what I've been scared.
Maybe the PowerPoint, which is coming, it not supposed to come PowerPoint.
No, I'm sharing the screen only.
Go to PowerPoint then. No, it's a wrong screen coming every time.
Okay.
Click on screen and PowerPoint.
Okay. Share. Okay.
Now click on enter and see if it is changing.
No, it's just not changing.
No, again, you have to stop and just close the PowerPoint.
Stop share. Okay.
I did so, and just close everything except the Zoom.
Okay, please do that. Yeah.
No, I can see. So so in the meantime, till the time I help her out, can you start with the introduction with the panelist and the question answer for the first speaker? Sarna? Sorry. Unmute yourself. Yes. You can start introducing the panelist and start with question answer. I'll meantime help her.
Okay, fine. Or we'll just just go forward for the third topic, or next we'll go for the that will be better, I think. So, hello, you can hear?
You go ahead, Sonia, it's all right.
Yeah.
You go.
Yes. So we'll go forward for the next topic, that is myopia control by Mr. Arnav Banerjee. He completed his bachelor in optometry, and also he completed his master's in optometry. And he's having special training in LVA in 2 months, in 2007 in Netra Niramaya Niketan. He's ex-orthopedist in Aravind Eye Hospital and ex-vision therapist specialist in Charity Eye Hospital. Currently, he's working as a senior optometrist in Shankar Netralaya, Kolkata. So, Mr. Arnav, can you please start your presentation? Can you unmute yourself?
Yeah, thank you, Shana. Can you hear me?
Yes, I can hear. You can share your screen.
Yeah, thank you. Yeah, just a second. Yeah, is my screen visible?
Yes.
Thank you all. Thank you, Sarna, for inviting me for the talk. And it's really a very happy World Optometry Day after 2 years of COVID-19, which we have been suffering from. And it's really I don't know how long this virus is going to be here. So as we know, the myopia control is a very, very vast topic, and it's very difficult to say within a very composite time, but I have tried my best to do in a nutshell. So if anything points goes out, or all of us are welcome to add any point if you feel. So as you know, the myopia is going to be by the year of 2050, about 50% of the world's population are going to be myopic. And as per World Health Organization, -5 diopter or worse is considered as high myopia. Now we know that with increase in myopia, there are chances of maculopathy, retinal detachment, glaucoma, and cataracts. But studies have shown even this maculopathy, retinal detachment, glaucoma, cataracts can be associated with low myopes as well. So consider in cases of high myopia, it can be so severe. And this is a diagrammatic representation of what is the myopia in whole of the world. Like in 12 to 13 of years, UK has almost got 23% of myopes. That too, it was done in the year of 2006-2008. In Iran, it was around 8% of 15 years of population in a census done in 2010. In China, it was a huge of 47%, China and Singapore. In Hong Kong, it was the highest recorded. It was 62% within 12 years of age, and the census was done in 2005 to 2010. But comparatively, it was less in cases of Iran and Chile and South Africa, where there are more open spaces. So in Indian, what about Indian population? In Indian population, a study done back in 1983 showed a 4.79% among school children in Chandigarh, that too in urban population, it was very much high. And in 2009, in 2002, there was another study which was done in Delhi. In 5 to 4% of was in school going children was myopic. In 2002, in another study in Andhra Pradesh, it showed that at the rural location, there was about 4.1% of the population was affected. In a very famous Andhra Pradesh eye disease studies showed that among 3.71% of total refractive error, 2.81% was myopic. So you can think of the large amount of population which had been suffering from. And in a North India myopia study in the year of 2015, it was said that total of 9,884 school children were screened, and the myopia was around 13.1%, with only 1/4 of those wearing spectacles. So within these whole school children, 13% was myopic, but only 1/4 has got an option or got a chance for wearing glasses. But the myopia control didn't come so late. It was in the beginning of the 19th century that first reported use of atropine to slow down myopia progression. But at that time, it was used of higher concentration, and as we know, with the higher concentration, there was chance of mydriasis. There was no progressive lenses at that time, and there was no photochromatic lenses. So the difficulty with accommodation or reading after myopia use or extreme photophobia was not get treated until 1970, when the treatment got revitalized due to this development of these lenses. And also studies showed intelligence, academic advancements, near vision use, professional schools, and people confined to restricted spaces, influence of specific genes and environmental conditions. All this leads to myopia development. So what is the concept behind it? The concept in a nutshell, which is known as hyperopic defocus. So this is on the figure. If you see in this blue arrow, when the rays focuses behind the retina, the eyes try to
Hello. Please unmute yourself. You're muted actually. Hello, Mr. Arnav. Can you hear? Please unmute yourself. I think Oli can give access to unmute Mr. Arnav.
Yeah, sorry, I'm audible. It
It's
was
okay.
showing it was not giving permission.
Yeah, it's okay now. Please.
Okay. So it's an hyperopic defocus which results as the rays falls behind the retina. So the eye tries to compensate for that, and as a result, there is a change in whole axial length. So this is the hyperopic defocus results in the stimulus for further increasing eye axial length. So these are some of the risks we all know associated with retina. This is just the pictorial diagram. So what are the risk factors? If there is no myopic parent, the chance of getting myopia to the less than 10%. If there is a one myopic parent, the chances increases to 15%. And if there are two myopic parents, the chances increases to 45%. And also there are environmental factors like near work, increased near work, academic intelligence, occupation, less in myopia. And there is a study which has very recent study. It was published in 2021, which showed there is a presence of APLP2 gene and high amount of reading. So they have divided one group with high amount with reading more than 2 hours in a day, and they have with no genetic variant, no APLP2 genetic variant, and one group was given high amount of reading more than 2 hours per day with this genetic variant. So it was shown that the persons affected with this kind of genetic variant has a higher effect on myopia progression rather than the person who doesn't have this kind of genetic variant. So initially it was thought accommodation results in elongation, but various studies showed that elongation is not based on accommodation. Initially the higher concentration was used, but then the use of higher concentration caused various side effects. So they went and on the washout effect means when it was stopped, it was seen that the myopia got rebound back. So they tried with a lower concentration, which works by a neurochemical cascade and which blocks the signal for axial elongation. So we need to assess low hyperopia for their age. So if a person comes, suppose a 4 years old kid comes with +1, we have to be like we have to screen them for whether the myopia on the later stages. We need to do a cycloplegic refraction. If there is a -1.5 diopters in one eye, no myopic shift within a year. If you have my patient who had already myopia and there is no myopic shift within a year, we can say okay, there is no progression. But if it is within -0.25 to -0.75 diopter per year, we can say it's a moderate progression. I mean, if it's a more than -0.75 diopter, we can consider it to be a fast progression. So what are the dosages and that ancillary tests needs to be done? Generally, if it is like very progressive myopes, study says you can start with 1%, but you have to be careful, like you have to give progressive lenses, you have to monitor very closely because of the effect of the atropine, and then you have to slowly taper. And if the progression is not so much, initially you can always start with a lower atropine concentration, but nowadays, if the patient is very progressive, we can start with a 1% atropine. But if the patient is very progressive, we can start with a 2% atropine. But nowadays, if the patient is very progressive, we can start with a 3% atropine. Initially, it was said you can start with higher concentration, but nowadays, whether it's a fast progression or a slow with a lower concentration, because of the lesser stop. If you stop the myopia, if you stop the atropine drops, that is within the washout period, generally there is not much of changes in myopia. And it can be used with combination with other treatments. And if there are complications, generally with lower concentration, we don't have complications, but if any, it can be managed with progressive addition lenses and photochromatic lenses. The tests which needs to be done with each visit is axial length measurement, cyclodegit, autoref, NRA and PRA, MEM, and near vision testing with near cover test. Also, you need to do a cover test, proper cover test, because sometimes the cover test will come into the subsequent slides as certain conditions, different type of approaches may also help. So, if the patient is having a rapid progression, like with -1 diopter or more, you can have a 3-month follow-up. And if it is like moderate and slower progression, you can take around 6 to 12 months of follow-up is also can be done. But atropine has got some side effects. We have to be like very very watchful for those side effects if there is any. And what are the other treatments? Initially suggested that commonly prescribed single vision lenses, and many of us would have in our initial days have come to the fact that you should if it should not fully correct the myopia. But a study has shown that the one group was given full correction and another group was given under group had a lower increase in myopia rather than the lenses. There is a huge study of COMET, correction of myopia trial, and the near isophoria. They may benefit for progressive addition lenses. So similar study, another study done in Japan suggested that early intervention with progressive addition lenses works better than single vision lenses in only patients who have got accommodative lag and isophoria between 6 to 12 years of age. There's another SLAM study which is done with RGP lenses and with soft lenses, and there it was shown that there is no difference in axial elongation between the two groups. So it was concluded that RGP lenses doesn't provide much help in cases of myopia control. Orthoteratology is a very promising promising method. It's a reverse geometry design. We all know if it's born overnight, it results in a flattening of cornea and its effect remains throughout the day. But they are limited to moderate myopes only, up to -5 diopter as per what the research shows. But as it's a contact lenses, you always have a chance of some infections, some iron deposits, some microbial keratitis, and also orthoteratology is a costly procedure. Now we move into the spectacles. So these are the spectacles which are generally available from the different companies, and these are some of the designs which you can see. You can see the dotted structures in the lenses, which helps to combat with the defocus in every portion of the retina. So what is the risk profile? So if there is a family history of myopia, so if there is no family history of myopia, then there is a low risk of getting myopia progression. If there is one myopic parent, there is a medium risk. If there is a 2 myopic parents, it's a very high risk. If there is no isophoria, no convergence excess, the risk is very low. If there is a medium risk, if there is some amount of isophoria or convergence excess, and in case of high, if there is some presence of isophoria, the patients are at higher risk. The vision or the refraction is at age appropriate, then there is a lower risk. If it is less than age, less than the recommended age, then it's at medium risk. And if the patient is already myopic, it's an higher risk. If there is no accommodative lag, then it's normal. There is no risk. And if it's a borderline accommodative lag, we know the accommodative lag between +0.2 to +0.75. Greater than that, we consider to be higher lag. So if there is a higher lag or a borderline lag, we can consider as a medium risk. And if there is a high lag, we can consider it to be as high risk. In the environment outside, if the patient or the child is exposed to the sunlight more, or if they are going out to play more, they are reading a less hours in a day, they are at lower risk. If it is at less than 2 hours, they say, they are at higher risk. And if it is less than 1 hour in a day, or if they doesn't goes out at all, they are at very higher risk. And if they are spent a close vision task less than 2 hours a day, it's a low risk. If it is 2 to 3 hours, it's a medium risk. And if it's like more than 3 hours in a day, if it has higher risk of developing myopia progression. So to conclude, RGP soft contact lens and uncorrected single vision lenses are ineffective in slowing the myopia progression in children. Atropine 1% is not used nowadays, most of the places. Orthokeratology is, though it's a promising thing, but there is a cost factor and the chances of affection. Progressive addition lenses has got limited effectiveness. You cannot give it to every myopic patients, and some drugs are not readily available. Atropine with photochromatic and addition lenses, if there is a side effect. Generally, we don't see much of side effects with 0.01%. And with the latest development of the spectacle lenses, there is a study which was published in 2021. The 70% of the refractive and 60% of actual length was controlled for high spherical lens rate. This was the design, and 40% refractive and 30% actual length for slightly spherical lens set in childless children. So glasses do provide a very viable solution even in cases of myopic progression, but those are called myopic control glasses. So always, not only you have to wear those glasses or atropine, you have to have some healthy lifestyles also. You have to have a healthy and balanced diet, have a regular eye breaks. We should wear protective goggles when playing sports, have adequate room and table lighting, and always you should hold the reading material at least a bit distance. It should not be, you should not move very near, and you should have daily outdoor activities, which is very, very important. So if you are in a more confined space, your chances of developing myopia is more. Thank you all. So if any suggestions or comments, I'm free to, I'm open to all.
That was wonderful, I think. Yes. Sonia.
Yeah, very nice presentation.
Right.
Can you please stay for the panel discussion? After one presentation, there will be one panel discussion. So please stay for 15-20 minutes at least. I'll just request for you. So ma'am can go ahead.
Yes, we'll appreciate that. Thank you for this wonderful presentation. And very sorry for the technical error for the last presentation. May I invite Professor Dr. Sonia Nankani once again to start her presentation. And let me just help her in sharing the screen. Yeah, ma'am, can you share your screen? And you have to also unmute yourself. Great.
So I'm so sorry about the glitch that happened. Hopefully we will be able to do this smoothly now. So the topic to discuss today is digital eye strain. And where are we heading to?
About 3 billion people around the world use internet, with India alone having close to 500 million of them. From children to adults, almost everyone uses mobile phones, laptops, or computers. Digital eye strain or computer vision syndrome is an epidemic today. About 3 billion people.
So digital eye strain, in today's world, we are seeing that almost everybody is dependent on some form of a screen or the other. So whether it is the housewives, whether it is the TV screen they are on, or people are working, there's work from home. There was, during the pandemic, we had children who were working, who were on school, which was all on the smartphones and on the laptops. So there is a strata that could not even afford the screen of the minimal 11 size or whatever. And so they were with the children who were doing schooling even on smartphones, and senior citizens, because they connect with their families across the world on Zoom or on whatever medium or on WhatsApp calls. So they are also using some form of the screen or the other. So what is this digital eye strain? It is also known as the computer vision syndrome. Now, this is a condition that results out of a continuous focusing of both the eyes on a computer screen. And it has been seen that of the people who use screen continuously for more than 3 hours, at least 70 to 80% of them may have some symptoms or the other. So what are these symptoms? It's not unusual for us in our clinical practice to have young adults or people in middle age, pre-presbyopes, the elderly, the children coming to us with vision which has been corrected. Either they don't have any glasses, so they are emetropic, or they may have some refractive errors which they're wearing appropriate refractive correction for in the form of glasses, but they still complain of headache, a strain in the eye. They may have blurring of vision. Some come with double vision, fatigue, tiredness. Many of them come with burning, just some irritation, pain here, pain there, pain around the eye, pain around the neck, pain, shoulder pain. It's just so much that they come to us with. And of course, after we have done a complete evaluation and ruled out all the other disease forms which are possible in the eye, ophthalmologically linked diseases, if we are able to rule out everything and we find, okay, now this person has 6/6 vision with or without correction, he's N6, this person is not having any problem with the anterior segment, this person is having a normal fundus, but still he's having all these complaints. So where are we heading to? So as I said, these are the things we do. We look for the monocular visual acuities, do a good slit lamp examination, see that they have a stable tear film, and then we do an orthoptic evaluation in which we do orthoptics for binocular vision. We rule out phorias, we look for the accommodative facilities, and we look for the Convergence dysfunctions. So all of you would know this probably much better than me, the assessment of binocular vision, which is generally done with a cover and cover test, the Worth 4-dot test, stereo acuity for distance and near. And then we come to the patient's accommodation, where we look for all these parameters of accommodation. And we know that to say that the accommodation facility is normal, it should be above 13 cmP. Similarly, now if we go to convergence insufficiency. So many people, they come and they are working on screens, so they're holding their eyes together, holding a focus together for long hours. So what is this convergence insufficiency? It's a binocular near vision disorder. It's both a sensory and a neuromuscular anomaly. And here, the ability of the eyes to stay turned in and to hold the object in a single vision it's difficult. And this is whenever we are trying to look at any object and hold it in near vision, we must be able to form a single image of it. And that happens only when both the eyes converge and hold that focus. So this ability to hold the object in focus reduces markedly. So what are the characteristics that we come across? So in CI, we see that the exophoria for near has become more than that for distance. And so also the measurements for the near point of convergence and the positive fusional convergence, nothing is falling in place. None of them are where they should be. So here we find that the near point of convergence has receded and it is more than 10 centimeters. Or the positive fusional convergence, with otherwise should be 35 at 30 PD, has gone haywire completely. So there is a traditional way of doing or of evaluating accommodative infacility and convergence insufficiency, which is what we were all taught all along. That's what we've been doing, because this is what we were taught in our colleges and in your optometry schools, and we in our during our post graduations. So that was a traditional method with a lot of armamentarium, lot of equipment we used to use. And some of them were so cumbersome to use and difficult to use. And that is the reason why most ophthalmologists, because it's not forced upon us, we just don't want to do this. But now we have some methods by which we can do this orthoptic evaluation in an easy way. And this is, it is through some computerized screens and through some computerized softwares, wherein the entire thing has become a dream now. So even for non-optometrists like me, who is more into doing surgery, who is more into clinical ophthalmology, I will not mind spending my time to evaluate this because it is quite interesting now. So initially, for these patients who come to us, now let's get back to these patients who are coming to us with headache and eye strain. So what we do is we do an orthoptic evaluation with the help of a program, which is like we give the patient a questionnaire and then we try to grade their symptoms. So there we get an asthenopia score out of them. And then depending on what the score is, you can see here, there are some scoring patterns given here. So what we are getting, whether it is severe, mild, severe, moderate, or whatever, then depending upon this, the patient is further taken on to do the other tests and on this software. And through this software, we now try to find out what is the accommodation facility with flippers, what is the fusional divergences for these patients, and whether they are following in a normal reference range or whether they are following out of the normal reference range. So the Convergence Insufficiency treatment trial, or the CITT study group, they have classified the CI as a classic one and as a common one. So now if we go to see what is the prevalence. So the prevalence of CI is about 1.75 to 33% according to the different studies. And there are a whole lot of studies which I have enumerated here. You can see them. So they are all saying, all of them say, some say that, okay, the prevalence is 25%, some say it is 7.5%, but it is all saying that there is some amount of convergence insufficiency which is present. Now we come to some data which whatever is available to us for the binocular vision status in a person who in the computer users. So we find that almost if we take it in percentage basis, so almost 41% of them will be normal. These may be the young individuals. These people who are using computers for long hours, they may be in the below 30 age group. Then we find that as the age becomes more, the complaints or the symptoms start increasing in these computer users. So we find that 15% of them may have convergence insufficiencies, and 25% may have accommodative infacility, and 17% may have both the convergence insufficiency and the accommodative infacility. So when is intervention required? Do we treat everyone? No, those who are normal will never come to you for treatment. So you just leave them alone. Now we have another set that is asymptomatic. They may have some they may have CI or they may have accommodative infacility, but they are not showing them as. So when we do the test, we are finding that they are having issues, but the patient comes and sits in front of us and says, oh, we are very comfortable. No, we can use our computer screens and our eyes are not giving us any features of strain. So these people, some of them may go. So here the intervention is optional, and this forms almost 20% of the whole crowd. Now, out of this, now we come to another set, which are the symptomatic binocular vision disorder people. And here, intervention is must. Why must we intervene here? Because of their symptoms, their compliance to work or their effectivity at their work is dropping. So they may, whatever their work is, they may be losing almost 20% of their efficacy. So coming back to the treatment modalities, now we have accommodation in facility, which can be treated traditionally with flippers or with vision therapy. CI, we can do the pencil push-up therapy, we can do the orthoptics or the vision therapy, we can go in for surgery, we can go for base and prism. So there are options available to us clinicians, and we know that we can do something for these patients, but we know that some of these procedures can be quite cumbersome to both the clinician as well as to the patient. So this is, I've just tried to show what pencil push-ups are like. So we know that if we tell the patient to do the pencil push-up, he will comply and he will do it for a few days, and then he'll say, oh, I don't want to keep doing this, and you'll have a dropout over there. So though this is a simple and the cost is low, we have seen that in the CITT study, there is a decrease in the mean symptom score form of almost 37.6 to 26.5 plus minus some 7.5, 7.3. But in these cases, we have also seen that only if we take about 100 of these people with this pencil push-up, only 46.7 who have adhered to doing the treatment have achieved a normal NPC at the end of the treatment.
Binocs offers quick diagnostic tests for the measurement of heterophorias, amplitude of accommodation, accommodative facility, divergence and convergence. It also offers therapeutic options which can be done in the clinic or home-based.
So we now have programs which are again which can be delivered on the computerized platforms, which are faster. So they give you recovery faster. The patients don't get so agonized by doing it's like doing physiotherapy for them basically, and telling a person that every day you have to do these stretches can really be irritating to them over a very long time. So if there is an alternative which is easier, simpler, quicker, why don't we adopt that? Now, we've seen that treatment of CI through vision therapy, you can have a systematic program. And the plus point here in vision therapy is that you can customize it to every individual. You can offer it in your office, you can offer it can be home-based. So during the pandemic, when everything was being done from the home, why couldn't we do this? This was something which was a boon, because this home-based therapy, most of the patients would love to do this sitting on their own couch. And the success rate is great. So all in all, it is a win-win situation for both the patient as well as for the clinician. And with this, it has, with vision therapy, the CITT study has shown that the symptom score falls to almost, the success is almost 92.4% here. Apart from that, for digitalized train, work ergonomics play a huge role, and we all know that. So there is this image you people must have seen several times where they say this is how you must sit, your back should be straight, your screen should be placed like this. So this is a very common image on work ergonomics. So just to recapitulate, lighting plays an important role. How bright is the screen and how is it balancing with the light in the surrounding room? Also, the visibility of the screen, there should not be any glares, reflections on it. Ideal amount of light should be around 20 to 70 candles or 200 to 700 lux. And the negative contrast computer displays, that is dark letters on a light background, are usually ideal. Now, there is also work ergonomics to the station, at which how the station is being designed. So we say that the eye should always gaze downwards by 15 degrees while viewing the screen. The top of the screen should be below the horizontal eye level. Then the viewing distance should be at least 20 to 28 inches, and you should not have an AC blowing into your face. There is a lot of counseling that can be done for these patients. They have to be taught the 20-20 rule, work for 20 minutes, break for 20 seconds, look away from an object, look away from the screen at some other object at 20 feet. So there is a lot to it. The tear film has to be restored for dryness through whatever dry eye treatment that is available with the clinician. Either it is in the form of eye drops, which are most common, or it can be or they can be the newer modalities of treating dry eye. So there is a lot that is to this computer vision syndrome. And the take-home message, I would say that many patients with the symptoms of dry eye syndrome or with digital eye, I'm going on to dry eye, to digital eye syndrome, have convergence insufficiency or accommodative infacility. Now, these patients have to be taught how to modify their workstation ergonomics. They have to have a good and a correct refraction to them. They have to be treated for their dry eye. And in the end, I think that what would be most effective for these patients is a few sessions of vision therapy, because I know for sure, having worked with this for so long, that it does really give excellent result and it does really give relief to our patients. Thank you. And once again, sorry for taking time in the middle and we're just not able to get it started.
No, appreciate your efforts of making this so simple. And today's time, I think the era of binocular vision practice is, I think, is going towards more and more of this non-strabismic binocular vision disorder management, like convergence insufficiency and accommodation in facilities. And I would, every one of us would agree that this is one of the most simplest tool or the things that we need to look at to manage this kind of clinical conditions. And if that can be done during this era of digital revolution, I think it's time to embed this practice of binocular vision, all of us. Thank you once again.
It was a complete pleasure. Thank you. Thank you very much for inviting.
We want you to stay back for a few more minutes. We would like to invite our panelist for next 5 minutes. Mr. Sonia Nankani will introduce the panelists, and if they have some question for all previous 3 speakers, we'll take those questions up, and then we move to the next speaker. Over to you, Sonia.
Thank you, Obi. I just want to request our panelists to unmute yourself. Like 4 panelists I want to introduce. First one is Anirban Paik. He's completed a PG in clinical research, previously worked as research coordinator in Lakshmi Eye Institute and academic faculty of Lakshmi College of Optometry, India. Currently working as senior optometrist in Shankarnetralaya, Kolkata in pediatric and myopia clinic. Second, Kirti Mitra graduated in 2012, completed her master's in optometry in 2017. She is ex-lecturer of Lotus College of Optometry in Mumbai, currently working as an assistant professor for Poilan College of Management Technology, India. Third, Mohammad Shuhel is graduated in Al Salama College of Optometry in 2009. He is ex-employee of Cornea Foundation, Dr. Agarwal's Eye Hospital, Chennai. Pursued his fellowship in binocular vision from Shankara Academy of Vision, Bangalore. Currently, he is working in Zayed Military Hospital, UAE. And last, Shobik Bhattacharya completed Bachelor in Optometry and his fellowship from LV Prasad Institute, India. Currently, he is also working in Zayed Metrid Hospital as an optometrist. So we can start our panel discussion for the last 3 topics: importance of history in ophthalmic patient, digital eye strain, and new pandemic and myopia control. Shuhel, can you start?
I don't see the name of Mr. Shuhel, and can other panelists can you come on camera?
Yes, Mr. Shovik or Kirti or Anirban, can you start, please? If you have any question, you can ask.
I saw him. Perfect. Yeah, panelists, do you have any questions to our earlier speakers? So please go ahead.
Okay, first of all, thanks to Mr. Sharna Kamal for arranging such nice event, and Oli, whom I have known for so long, and he's always up to new things. When the first time I heard about JAWS software was back in 2008 and 9. Before that, it was just an Hollywood movie for me. So thank you, Oli, for arranging such a good event from us. Mr. Ujjal has covered all the points. So I just can share my clinical experience about history taking. That the first point, very first point, which he has mentioned, that the rapport with the patient, that is actually the very important part. So the ice-breaking part is very important, because you all will understand when in our initial days, when we used to take history, we always used to wonder why we are missing some points when the patient is visiting to the specialist consultant, because the point was ice-breaking. The patient doesn't want to reveal all the histories on the first go. That was the problem. Like just few days before, one patient from Sharjah, he was hiding something that I could not understand. It is my inability. I acknowledge that he was having methanol. He was a construction site worker. He was having methanol because he was not getting alcohol. Because this point he was hiding from me, I was not being able to make the provisional diagnosis. So this ice-breaking part is very important on the first go, because the history taking part is so important that it just makes the 50% of the diagnosis. Otherwise, all the points he has covered was very comprehensive. And any other panelists, if they can add up some points.
So I have been into practice for the last almost 27, 28 years, and the gadgetry has only come in the last 20 years. So before that, it was just history taking, which you are saying 50%, but I would say 75 to 80% of your diagnosis lies in the history. So a good history takes you beautifully to your diagnosis, and then it only leaves us with the clinical paraphernalia or the clinical examination to get to a good and a correct, robust diagnosis. So history taking is an absolute, it's a craft actually. And the more nuanced it is, the better it is, the easier it is for the clinician to come to a final diagnosis. Thank you.
Hi, thank you for inviting me, and it was a great presentation. The one thing what I have faced during my practice was, sometimes some of the patients, they consider that revealing history to the optometrist or anything, any clinician, they, it's something. If they reveal their histories, then we may miss something. It's like the doctors or optometrist should find himself rather than revealing themselves. Though these kind of mindset in at least very few, percent of the patients I have faced during my, practice. So how do you handle these kind of situations normally? Is there any shortcuts to open their minds or something like that?
Now, who is this question directed to?
Yeah, first maybe the speaker, Mr. Arnav Banerjee, if you can answer the question. Mr. Arnav, you are still there?
Yeah. I'm sorry, I have got a tremendously bad issue with the network today. Yeah. See, as you were speaking rightly, sometimes the patient do not want to reveal everything to the optometrist. Is what you were asking. Have I got that question correctly? That if all the time, many of time the patient doesn't want to reveal everything to the optometrist. Was that the question? Yes. So yes, this is very true. Many a times optometrists don't want to reveal all the questions to us, all their problems to us, but only thing which we could get into those, or we could take out from the patient, is by like detailed history taking. Like if there is a headache, if the patient comes with a headache complaint, and if we ask, okay, headache is like, where is the location, what is the frequency, and where does it radiate backward, or is it associated with nausea and vomiting, or how many times in a month you get it, or is it associated with reading or writing? Means you have to ask those questions which will ultimately force them to reveal all the answers to you, whether you have done any systemic investigations, any CT scan, any MRI has been done or not. So all those questions needs to be asked by the optometrist. Even in those patients who are not willing to reveal everything to the optometrist, they might want to go to the consultant ophthalmologist and want to say. Many a times it has seen, even those patients have also come who want to cross check. Like they will come and say, I have gone to this place and they have given me and I have facing problem with the glasses. But they won't show you the detailed prescription, what things were done, whether any what is the logic behind that prescription, whether what he or she has been said. So those things we have to put out. We have to ask them repeatedly, like what things were done, whether any treatment was done, whether any other investigations was done, what was the advice to you by the respected person from that place. Even if they doesn't want to say, then it is always good. What I do is that I say them, if you don't reveal all the points to us, if I feel they are hiding something, and I said, if you don't reveal all the points to us, we are not going to make a proper diagnosis. So that is the thing which I could think of, if in those kind of patients who doesn't want to reveal every situations to us.
Great. I think that gives a lot of value addition. Can I invite Mr. Projal to, Ujjwal to add some comments if you have something?
So the first thing what I can say is, yes, as the first panelist pointed out very correctly, the rapport building. If we can break the ice, if we have a good rapport built up, most of the time they say the required things. Only at times it happens that even with a constant effort, you don't get anything. There are people where we have to give up, like, okay, they're not revealing, and it will go to the ophthalmologist and will reveal up. But if it is coming to us when we are the only clinician, say in private practice or somewhere like that, there definitely we need to put that constant effort. One thing that commonly that I face in my daily practice is especially if someone is coming for a second opinion for glasses or something else, they tend to hide the thing. They do mention that we got something and there is the reason that we are here for a second opinion, but they don't give the every detail that they have. What I prefer in those cases is, like, I start my things and I almost towards the end, when I'm done, say for example, that time, once I'm done with the acceptance also, that time I ask if they already have the previous glasses prescription so that I can compare. At that time, most of the time they do reveal yes, they have the prescription or they have the glasses, and then we can compare easily. So yes, this is a challenge, but as people do say, like, history taking is not only a science, it's also an art. So I feel it's more of an art than a science. Science part will help us to come to the diagnosis, and art part will help us to get the information that is required. That is my take on this.
Perfect. I think that gives a lot of information for us. As we are maybe running short of time, can we have maybe one question to the other panel speakers? So one on myopia management and one for binocular vision related digital eye strain. So any of the panelists would like to have question for two of the speakers?
I think I can unmute Kirti.
Yes. Good evening, everyone. First of all, thank you to Mr. Chandra-Kamal Naya and Mr. Oliullah Abdal for inviting me in this panel. So I would have a different question from myopia control part. So I have a question that how come there is a hyperopic defocus for myopes, like hyperopic defocus for myopes actually trigger myopia. So how with the help of measurement of peripheral refraction, how can we conclude, or how can we control myopia? How does peripheral refraction helps in controlling myopia? So this is my question to Ornup sir over here.
Is it okay if I put my video off, because I think I've got some network issues?
Go ahead.
Yeah. So what happens is, like in myopia control, the center part, if you are focusing in cases of a patient, the peripheral rays get a hyperopic defocus. So as a result, the eyeball starts to elongate in order to accommodate those peripheral rays, and as a result, there is an increase in myopia. Now, this was initial theory which was been formulated, but on the latest say, this is called the simultaneous myopic retinal defocus, the latest theory which has come into play, which says one of the ray will be on the retina to correct myopia, and another will be in front of the retina for myopic defocus. So one will take care of what the question you are saying, and another will be taking care of so that the eyeball doesn't elongate. So that is how we now the latest perceptive has come, which is known as the simultaneous myopic retinal defocus theory. Is it okay?
I think that's answers maybe the question. Do you have any question for our third presenter, Professor Dr. Nankani? Any question? Anyone? Kriti, you have any question? Or Mr. Anirban or Mr. Mohammed?
Thank you.
Any question, Kriti?
Yes, I would also. I have a question for ma'am. So, I would like to ask, what is the base treatment possible for convergence insufficiency? What do you suggest, madam?
So for the last 6 years, I have been using Binocs, and I'll be very blatant in telling you this. So it's a software related treatment, and we give the patients around 25 to 30-minute sessions for about 7 to 10 days. And definitely the values go up, the complaints go off. That's exactly what I have been doing. For the last 6 to 7 years, that's what I've been doing, because I always found the pencil push-up absolutely impossible to do. And it takes so much of the chair time of the optometrist, of my optometrist, and we just gave it up. So it's been, actually, we were also quite blind to the needs of binocular vision. Problems like CI or accommodative facility, maybe before 7-8 years. So it was something which we just didn't really look into. And it was only after we got this software platform that we started really working hard on it and looking for it. And now we feel that, oh, it's solving so many problems of so many patients, especially those who are working on the computer screens. So this is a very truthful response to you.
Right, ma'am. So does it revert back? And if it reverts back also, like how do we monitor? Will you give home exercises as well? Home vision therapy exercises as well?
Yeah, so basically we have been doing only home vision therapy throughout the pandemic, and even a little before that. The platform was always, home-based therapy which was being given. And yes, if somebody is going to abuse their eyes continuously, and if they're going to continue to work 8, 10, 12 hours on a screen, and which is what was happening throughout the pandemic with this work from home, people didn't have an option. So whether I use the word abuse or not, but that is what was happening. And if first they would work on the screen, and then they take a break, go out and go to their living room and then watch TV over there. So from one screen to the other screen, that's all that was happening. So work, play, enjoyment, entertainment, everything was on the screen. So yes, people do, even after doing these sessions, people can slip back into, or the values of CI can reappear, and people can slip back into CI, but it doesn't happen so soon. It takes around a good 15 months to 2 years time. And at that time, if they are coming back with a similar complaint, you can just give a booster session. Maybe just 1 or 2 boosters is enough to again pump up that value and bring the patient out of CI. So this I'm talking from my experience, not only in the last 2 years, but over the last 7 years.
Right, ma'am. Thanks a lot, ma'am. Thank you.
Thank you once again. Thanks to the speakers and as well as the panelists. I think we had a wonderful session. We're concluding this first set of speakers over here. As we move on to the next topic, we have Mr. Sarath Raj. He is a clinical optometrist and LVA specialist, though he's currently working as a territory manager and product specialist in Medical International Dubai. So I'd like to invite Mr. Sarath Raj for his presentation today.
Hi, everyone. Can you see my screen?
Yes.
Yes.
Okay. Hi, everyone. Basically, I'm working in UAE as a product specialist and contact lens specialist for Medicals International Company. So we deal with specialty lenses, hybrids, low vision aid products, and Cooper vision products. So this is my experience, and I'm working in UAE from last 10 years now. So basically, if you go to in UAE, in the GCC country, we are covering all the GCC countries where you can find a many cases of keratoconus patients. So Rosca XL lenses, this is not a full scleral lens. This is also called as a semiscleral lenses. Large diameter can improve the centration of the lenses. Why semiscleral contact lenses? Cornea, one of the most highly sensitive tissues in the eye. Small RGP lenses that rest on the cornea may induce discomfort. So the back, like 10 years back, there is no other options of patients to see better with the keratoconus cases. So they used to compromise their comfort to see better. So they used to use a normal small lenses. So now after that, the Rose company, they introduced the Rose XL lens, which is a bigger diameter, which is called a semiscleral lenses as well. So it will give the more comfort because the landing zone of the lens is in conjunctiva. So conjunctiva sclera is much less sensitive, easy to fit, simple to use the fitting systems, a wide range of parameters and edge lifts are available, provides ample oxygen level to the cornea, needs TS exchange. As a Rose XL lenses, they're using Minicon Z. The decay weight of these lenses is 165. So what are the cases we can use the Rose XL lenses? It used for keratoconus, PMD, post-graft, post-LASIK ectasia, or irregular corneas, corneal GP intolerance, corneal injury, severe dry eye. This is basically one solution for most, 85 to 90% of the cases of the keratoconus patients. So usually when you had a small lenses, you used to carry Rose normal, IC, PG, nipple cone, so all these options. But now Rose XL is covering 90% of the cases with one design, so which is very famous design now. We are using in GCC countries. So design aspheric back optic zone, which decreases as the base curve steepens, front surface aberration control, precise edge control, reverse geometry in the flatter base curves. So parameters available, the base curve start from 5.8 to 8.4. The diameter standard, we keep the 14.6 diameter trial sets, and we can make the trial sets from 13.6 to 15.6. But basically the running diameters we use is 14.6 in the trial sets. If the patients need a bigger diameter, we are using the 15.5 diameter lenses. So any power you can add with any astigmatism, powers even oblique also. Material is Minicon Z, and edge lifts 21 options are available, but basically we use 4 steps. One is standard, which is the normal, plus half and plus 1, minus half and minus 1. So this is the 5 steps. We 95% of the cases we are using the edge lifts. So Rose K to XL, the fitting steps, the base curve evaluation. First trial lens is 0.2 steeper than the average K or the condition guide. The advantage of the Rose K to XL lenses, it's having a condition guides inside the trial sets, where you can take the average K of the patient as per their condition, like if the patient is gone for corneal transplant or any other corneal surgeries, they will go 0.5 steeper than the mean K value. When you use that table, it is 90% of the time that table indicates what are the lenses as a first trial will be 90% of them the first successful fit. Only 10% of the time you need to go either steeper or flatter based on the patient's case. Insert the saline and the fluorescent into the concave side of the lens. Select the steeper or the flatter base curves until very light feather touch is achieved at the highest point of the cornea. So when it's come to Rose K to XL lenses, we want the lenses having a feather touch on the apex of the cone, where the this should be the 65 microns to 125 microns between the apex of the cone to the lenses, which is the feather touch of the lens. For the initial evaluation of the fluorescent pattern can be judged immediately. You don't need to wait for 1 hour, 1.5 hours. Just insert the lens within a 5 minutes. Just see the lens, how the lens is moving or the settle down in the eye. If you feel that this lens is more dark, more steep, or more pulling or bearing, then just immediately change and allow the lens settle for 20 minutes and reevaluate to the fit. Basically, for these lenses, once you get used to these lenses, you can do the fitting 20. It will take hardly 20 minutes for one eye fitting for the fitting. So within a 1 hour, you can both eye you can do the fittings, and it's very fast, accurate, and very easy to fit. Because why we are telling this one, because most of the clinics what we have a lots of patients. You cannot make it too much hurry with the keratoconus patients fitting. So in that cases, this Rose K to XL are more effective and more accurate and more faster. If the further fluorescence is required, place at the sclera at 12 o'clock to just above the lenses. Ask the patient to blink several times, so you can see the TS exchange between the lens on the cornea. And if the fluorescent doesn't appear behind the lens, manipulate the lower end or upper edge of the lenses. So what edge lift, how you can, once you've done the lens fitting on the center fit, then you can go for the edge lift. Observe the fluorescent pattern at least 1 mm of the lens all around the position of the clockwise on the round of the lens. If you look at the picture here, you can see all around the lenses there is 1 mm fluorescent pattern. Should observe the fluorescent pattern initially on the first insertion. The peripheral band about to be 0.8 to 1 mm is an ideal. Reinsert the fluorescent onto the sclera if several minutes elapse. Fluorescent should be circulated under the edge of the lenses if the edge lift is correct. Fluorescent band may be irregular if the peripheral astigmatism is present. Even judging the correct edge lift value. Combination of the edge lift, you have to go with the fluorescent pattern, comfort, the movement, how easily fluorescent enters under the lenses when you do the push up and down test. You have to tell the patient to look up and blink. You can see the fluorescent is exchange, the TS exchange is happening. And the comfort of the patient, ask the patient, keep on ask the patient like how you're feeling, you're having any pricking sensation or any other issues. Sometimes the patient will tell, I'm feeling that at 6 o'clock or 3 o'clock, 9 o'clock, I'm feeling something is having a pricking sensation or pain or something. And the movement, if the lens is having excessive movement, patient won't be happy. And if the movement of the lens is very, very minor, then the patient won't be happy. Patient will be going to face the hypoxia or the neovascularization due to the non-movement of the lenses here. So excessive edge lift. So in this case, you can decrease the edge lift or you can flatten the lenses as well. In insufficient edge lift, increase the edge lift. So ideally, you can see this picture where the ideal peripheral fit of the lenses, which is 0.8 to 1 mm at the edge of the lenses, which is the ideal fit for the lenses. If the lens is having excessive edge lift, you can see there is no fluorescent, it's a wide more than 1 mm to 2 mm edge, the fluorescent patterns on the peripheral of the lenses. And here you can see some of the places there is fluorescent patterns are missing, and the lenses are already started. You can see the veins are coming towards the cornea, which is the lens is set on the sclera. So 5 standard edge lifts we always use for the most of the cases. Very rarely we go to above 1.5 minus or plus edge lift. So diameter, recommended standard diameter is 14.6. The lens should extend 1.3 to 1 mm outside the limbus for an HVAD of the 11.8 mm. Changes the diameter do not affect the central fit of the lens. And that is the advantage of the rose scale lenses. If you go with the normal rose scale lens, which is a corneal lenses, whenever you are making the lenses flatter or steeper, or making the lenses diameter bigger, the lens will be more flatter. When you make the diameter of the lenses smaller, it will be more steeper. But the advantage of the rose XL lens is that when you see that the central fit of the lenses is fine, patient is happy, comfortable, everything is fine, but you want to increase the diameter or decrease the diameter, you can change it. So when you're changing the diameter of the lenses, the central fit of the lens doesn't change, the power or the comfort of the patient doesn't, it will be remains the same. For the larger corneas, increase the diameter, and the smaller corneas decrease the diameter. So location, the lens should be sit eventually around the limbus. Decentered effects may cause the lens locate downwards. To improve the location, increase the diameter or flatten the base curve. But when you have a standard diameter trial set like 14.6, in that case, you have only option is you have to flatten the base curve to give a better comfort to the patient. Significant decentration causes discomfort and corneal scaling. A slight decentration may not cause any major issues, but maybe slightly less comfortable. So sometimes there is a slight decentration will be there due to the corneal the effects of the corn. So in that cases, if the patient is happy or is not facing any issues, or with the follow-ups you are not facing any things, so then it's fine. For the minor decentrations, not too much of the decentration. Movement on the first instant of the lens, so the lens should move about 0.5 to 1 mm on blinking. Judge movement at 6 o'clock, patient look up and blink. After the lens settles, very little movement, about 0.5 mm. Even 0.5 to 0.7 is also acceptable, the movement of the lenses. And also over the lens, put the fluorescent and see the movement of the lenses, whether the tear section is happening or not. excessive movement will be uncomfortable for the patients. To increase the movement, you have three options: increase the edge lift, flatten the base curve, decrease the diameter. But in this case, when you have a standard trial sets, you can do a flatten the base curve. To decrease the movement, same, decrease the edge lift, stiffen the base curve, and increase the diameter. Basically, I'll carry both. I'll carry two trial sets, which is 14.6 diameter and 15.5. So depend on the cases, sometimes I'll change the lenses, the diameter of the lenses. But when you have a 14.6, there's a standard trial sets most of the optometrists are using in the clinics. So in that case, they have an option only the flatten the base curve. So an accurate hour refraction should be performed once the lens is settled on after 15 to 20 minutes. Wearing schedule, wearing and the follow-up schedule. First day, wear the lenses for 3 hours maximum. From the second day onwards, inform the patient every every 4 hours once or 6 hours once. Remove the lens for 5 minutes and clean it and insert it back. This is for the two reasons. One, you are adapting, you are making the patient adapt to the lenses, and they are getting a train to how to insert and how to remove the lenses. So this is like a 1 week schedule. From the second week, they can use the lenses for up to 10 to 12 hours per day. But after 10 hours, if they're feeling any uncomfortable, they can remove the lens and clean it and put it back again. And see the patient after 1 month follow-up or the third week, because there is a 1 month warranty for these lenses. So after within a 1 month, after the second or third week of the after dispensing the lenses, if the patient is coming for the follow-up, if you're seeing any changes need to be done, whether it's a power, diameter, edge lift, and power of the lenses, anything is a free of charge. So that's why it comes with the 1 month warranty. Then call the patient after 3 months for the follow-up. So this is the lens insert and removal procedure. The insertion will be filled with the saline solution and the fluorescein. This is when you're doing the fittings for the patient. After that, you don't need to use for the patient, they can just insert the solution. The patient should tilt head parallel to the flow to make sure that solution remains in the lenses. For the removal of the lenses, place the wetted suction holder on the outside temporal edge of the lens. Peel the lens off by pulling the outwards across and arc towards the nose. So don't try to remove the lenses suction holder from the center. So always inform the patient when you're removing the lenses, always you have to test the lens from 3 or 9 o'clock, then remove towards the outside, not right from the center. So it will be more painful for the patient. That's it. Thank you.
Thank you, Sharath. Thank you for your wonderful presentation. It's very much informative. Thanks for your time. Would you like to wait for your panel discussion, or you're having hurry actually?
Yeah, I'm having one more
another presentation, right?
Okay. Thank you so much.
Okay. Thank you.
Thank you.
So
maybe we can take up the question later on and answer the participants in a group if we have something. Because we are running late, so we may start with the next presenter. So, thank you once again, Mr. Sarath.
Thank you.
So we'll proceed for the next presentation, that is by Mrs. Anjali Ali, the approach to the patient with diplopia. Mrs. Anjali completed Bachelor in Optometry and Vision Science from West Bengal University of Technology and pursuing her Master in Optometry also. She is ex-optometrist of Shankar Nethralaya and Narayan Nethralaya. So, Mrs. Anjali, can you please proceed for your presentation?
Before we start the presentation, a very quick request, sincere request to the presenter, all of the next presenters, please try to stick on time because we are already delayed. Thank you.
Sir, am I audible?
Yes.
Yes, carry on.
Okay. Good evening, everyone. It's an honor and privilege to speak on the eve of World Optometry Day. Today, my topic of discussion is approach to the adult patient with diplopia. The double vision is a commonly encountered concern in neurologic practice. The experience of diplopia is always sudden and is frequently a cause of great apprehension and potential disability for patients. Recent population-based analysis have determined that diplopia is a common presentation in both ambulatory and emergency department. Binocular diplopia is most often due to neurologic causes. So today our main objective of discussion is history taking, associated signs and symptoms which we must look for, determining the pattern of misalignment. Essential questions means history taking includes monocular or binocular, onset, constant, intermittent, horizontal, vertical, torsional, changes with gauge or viewing distance, minimized with head positioning, sudden, gradual, variable, transient. Here, sudden includes like any ischemic disease patient is having. Gradual, in gradual, we must ask about comprehensive tumor, dysthyroid. In variable, we must look for myasthenia gravis, and in transient, giant cell arthritis. General health history is also important in a patient who complains of sudden diplopia, and family history also needed. Inspection include head posture, like head tilt, face turn, chin elevation, or depression, face asymmetry, eyelids, or vital signs like Cogan's twitch and trigeminal facial functions, pupil, and globe positions also. Globe position is important in thyroid ophthalmopathy and facial asymmetry. Monocular diplopia. Before proceeding to binocular, I'm putting special emphasis on monocular diplopia. It occurs when the two images are viewed by a single eye. Causes of monocular diplopia is light diffraction, metamorphia, cerebral polyopia. Light diffraction is caused by lid chalazi and edema, tumor, tear film abnormalities, corneal scar, dystrophies, ectasia, cataract, ectopic lentis, subluxated intraocular lens, iridodialysis, peripheral iridectomy, vitreous foreign body. Metamorphia is caused by cystoid macular edema, epiretinal membrane, central serous retinopathy. Cerebral polyopia is a very rare condition, but if occurs, it includes occipital or temporal lobe lesion, occipital lobe epilepsy, trauma, migraine, and encephalitis. Monocular diplopia is assessed generally by pinhole and then refraction, corneal topography, slit lamp examination, and fundoscopy is required to determine whether the diplopia is monocular or binocular. In points to remember for monocular diplopia occurs when the two images are viewed by a single eye. Monocular diplopia occurs in three conditions: light diffraction, metamorphia, and cerebral polyopia. Pinhole test will help in differentiating cause of light diffraction and metamorphia. Monocular diplopia can be both unilateral or bilateral in case of cerebral polyopia. If the diplopia is monocular, then it is mostly it is not the neurological one. So in binocular diplopia, the examination includes, first we have to do Herzberg test, Würth dot test, cover and cover test, alternate cover test for both distance and near without abnormal head position. So we have to measure and do the cover test without any abnormal head position. If patients acquire abnormal head position, then we will not get the correct amount of prisms. Ocular movements like Burson, Duction, Doll's head movement, and command movement. Assessment of deviation is done by three main tests: Park 3 test, step test, hair screen, and Diplopia Chart. Park 3 step test. This test identifies which muscle is paretic in patient with a heteroporia caused by an isolated vertical rectus muscle or oblique muscle palsy. The three-step tests are to determine which paretic muscle might be causing the hyperdeviation in primary position, where the hypertropia is greatest in right gaze or in left gaze. On head tilt, which side the hypertropia is greatest. Here I am taking the case of right hypertropia. If a patient comes and we see that patient is having right hypertropia, then how we have to proceed? This is the Park 3 step test. In first step, we have to see in primary position which eye is hypertropic. If the right eye is hypertropic, then we should understand that right eye depressor is not working, and in contralateral side the elevator is not working. So we have to mark that in muscles like right inferior rectus and right superior rectus. In the left eye, left inferior oblique and left superior rectus. In the second step, we have to see in which gaze, in left gaze or in the right gaze, the hypertropia is increasing. In this case, right hypertropia increases in the left gaze. So the left side muscle is marked with green, like right inferior oblique and right superior oblique, and in the left eye, left superior oblique, left inferior oblique. Then in the third step, which is also known as Belchowski head tilt test, then we have to see in which side after tilting the head, the hypertropia is increasing. So in this case, hypertropia increases in head tilt to right shoulder. So the right shoulder muscles, the right side muscles, which are responsible for the eye positioning is right superior rectus muscle and right superior oblique muscle, and in the left eye, left inferior oblique muscle and left inferior rectus muscle. It is marked in red color. Now in 3 steps, we have to see which muscle is common, and that the common muscle is responsible for the hyperdeviation. In this case, right superior oblique is common in all the steps of Park 3 step test. Hence, the affected muscle is right superior oblique muscle. There are some limitations for Park 3 step test, like in multiple muscle paresis, ocular restrictions, syndromes, myasthenia gravis, thyroid ophthalmopathy, dissociated vertical deviation. We are unable to find the responsible muscles for vertical deviations. We have to remember in these cases, if the patient is above 50 years old and presenting with double vision and ptosis, we must always look for myasthenia gravis. The second method for assessing the double vision is hair screen. This chart is useful in diagnosis and in judging the progress of palsy. The hair screen is used in paralytic squint to plot a chart which record under action and overaction of extraocular muscle and restriction of ocular movements. In this way, these recordings are being done. This is the case of right superior oblique palsy. This case of right lateral rectus palsy. I'm not going in details how it is being performed. This is the third nerve palsy. Here we can see the antagonistics, agonistics, contralateral synergistics, all the muscles, how it acts when any muscles is get paralyzed. Diplopia chart, it is also being done to assess how much to quantify the diplopia. This is particularly useful when a haze chart cannot be plotted, and also in revealing and recording image tilt. Diplopia chart gives a pictorial record of diplopia in cases where there is separation of the two images, changing with the position of the gaze. Here I have some cases which I have done in my practice. This is diplopia chart. This is third nerve palsy. Here the goggles are placed in front of the red in front of right eye and green in front of left eye, and a linear light is shown to the patient from 40 centimeter so that all the 9 cardinal position of gaze, and the patient informs how the image changes with the gaze, and we mark it accordingly. This is the case of traumatic third nerve palsy. Here the maximum separation of crossed image is in dextroversion and crossed L over R image on levo elevation. The cross R by L image on levo depression. Maximum separation vertically and horizontally, and if any any torsional image is formed, that also being marked in diplopia chart. Here, this is the case of left lateral rectus palsy. So after this session, we are going to summarize that we should make sure that the diplopia is not monocular, check associated signs and symptoms, must determine the pattern of misalignment, consider myasthenia in every patient above 50 with double vision and ptosis. These are my reference and this is my email ID. Thank you, sir, and thank you everybody for listening me patiently.
Thanks to you. Actually, it's a wonderful presentation on managing a diplopia patient, how to approach them, starting from history to the assessment part of it. Obviously, management comes at the end. We would like to come back to you once again with the questions after the next presenter. We have another interesting topic on neurooptometry. So today we have Mrs. Nandita Burman. She'll be talking on neurooptometry examination. To introduce her, she is very familiar face in neurooptometric practice, as she has done her master's in optometry, also fellowship in I think neurooptometry from renowned institution. Currently, she is working as senior optometrist in the Binocular Vision Clinic and Neurooptometry Center in Shankar Netralaya, Kolkata. May I invite Mrs. Nandita to start her presentation.
Yeah, thank you. Thank you very much for inviting me for this wonderful session. And neurooptometry and its evaluation, this is a very vast part. So today we are actually not having so much time to explain all that. I'll just go through it like overall of the neurooptometry. So we need to share the screen. I think Sharnakumal was about to share the screen for me.
Yeah,
hello.
Sure. Yeah, sure.
Yes. So the next slide. So for presentation objective, we can say that review of common visual dysfunctions associated with acquired brain injury and to understand neurooptometric care as a part of multidisciplinary team. Next. The treatment of binocular vision, accommodation, and eye movement disorders related to acquired brain injury is one of the more challenging aspects of optometric practice. So patients who survive acquired brain injury generally experience multiple problems, including cognitive, psychological, motor, and sensory anomalies. Even when binocular vision, accommodation, and eye movement problems occur in isolation of cognitive and psychological issues, they tend to be complicated. The cyclovertical and non-concomitant deviations, sensory fusion anomalies, unequal accommodation, and visual field loss may accompany the basic vision problems. So neurooptometric rehabilitation is an individualized treatment regimen for patients with visual deficits as a result of physical disabilities, traumatic brain injuries, and other neurological insults. Neurooptometric therapy is a process for rehabilitation of visual, perceptual, and motor disorders. So what are the primary causes for acquired brain injury? We can say there is brain tumors, the trauma, maybe then stroke, hypoxia, anoxia, and then alcohol related, any kind of infection or degenerative diseases like multiple sclerosis, Alzheimer's, Parkinson's disease, and all. Next. So the acquired brain injury, we can divide it as non-traumatic brain injury and traumatic brain injury. In non-traumatic brain injury, there will be anoxia and infection and stroke, tumors, and metabolic disorder related injuries. And in traumatic brain injury, there we can divide as open injury, open brain injury, in that we can have penetrating injuries like assaults, fall, accidents, surgeries and all. And in traumatic brain injury, if we divide the part is closed brain injury, will be internal pressure of shearing like assaults, falls, accident and abuse and etc. So all this in all this comes under acquired brain injury. So acquired brain injury is generally used to refer both the term traumatic brain injury and acquired brain injury, and stroke also, and cerebral vascular accident like CVA. Next one. So for traumatic brain injury classification, we use Glaucoma scale and the hour of post-traumatic amnesia and hour of loss of consciousness. So if the according with the Glaucoma scale, if the patient is patient score is 13 to 15 and the patient is having post-traumatic amnesia of less than 1 hour and loss of consciousness of less than 30 minutes, the patient is coming under mild traumatic brain injury. And if the Glaucoma scale score is 9 to 12 and the post-traumatic amnesia is 1 hour to 24 hours and loss of consciousness is 30 minutes to 24 hours, the patients are coming under moderate traumatic brain injury. And for severe, the Glaucoma scale score will be 3 to 8, post-traumatic amnesia more than 24 hours and loss of consciousness more than 24 hours. So studies concluded that the term mild traumatic brain injury is very misleading and does not necessarily translate to mild functional loss. This is very significant because most optometrists primarily encounter patients with mild traumatic brain injury. Next, please. So here the in traumatic brain injury or acquired brain injury, in every patient, optometrist has a great role. The frequent problems which not identified as being related to vision, like seeing objects appearing to move, that they are not known to be stationary, and reading difficulties not associated with blurriness, and the tilted floor, or maybe in problem for balancing and coordination. So the vision problems are common after acquired brain injury and have a significant negative impact on common activities of daily living, such as reading, writing, shopping, dressing, sports, and driving. The optometrist role includes management of refractive error, binocular vision accommodation and eye movement disorders, and visual field loss managing. Next, please. So the different symptoms may be there for this acquired brain injury patient. They may have dizziness, motion sickness, poor attention or concentration, inability to tolerate busy or crowded environments like shopping center where different color objects are kept in place. So the patient will have difficulty to cope up with that environments, and poor spatial awareness. Next. So the common non-strabismic binocular vision disorders are often associated with accommodative brain, acquired brain injury. Is most common problems found where binocular vision disorders such as accommodation problem like reduced amplitude of accommodation, increased lag of accommodation, reduced relative accommodation, and slow accommodative facility, and the Convergence problems also like convergence insufficiency, intermittent and constant exotropia. There are also a number of patients with vertical deviations also. According to studies, there are patients with accommodative and Convergent deficits were common in traumatic brain injury patients, and strabismus and cranial nerve palsy were more common in severe patients, severe like cerebrovascular aneurysm. The saccadic and pursuit were common in saccadic and pursuit systems were which are also may be affected, and the saccadic and pursuit systems have separate and distinct neurological pathways. Because of the pathways are distinct for saccades and pursuit, acquired brain injury can affect one of the system, leaving other intact. Next, please. So there are the symptoms which are related to oculomotor or visual system, which are common in acquired brain injury patients. They are most tend to avoid the near task. They have difficulty which are related to oculomotor difficulties, oculomotor disorders, not with blurriness or not with other things. And they will be having tracking or focusing problem. They can have eye strain and diplopia, as well as dizziness and vertigo also. And as the Sekes and Pursuit, all are they can have affected. They can be affected, so that they can have version derived nausea. They will be having increased sensitivity to visual motion, visual inattention and distractibility, short-term visual memory loss, difficulty judging distance, and difficulty with global scanning. Next one. So all this problem tends to difficulty for the patient with personal grooming, especially involving the face, and they will be having difficulty to cope visually complex situation or social situation, and inability to tolerate complex visual environment. Visual field loss prevent full normalization of reading speed and comfort. So in acquired brain injury patient or traumatic brain injury patient, the patient can have scattered scotomas, right homonymous hemianopia, left homonymous hemianopia, and bitemporal hemianopia with chiasmal injury. And in one of the cases, a right homonymous hemianopia continued to interfere with reading speed. However, in another, patients with superior right quadrantopia does not affect reading task. Next. So the implication of visual field defects, the patient can have reading difficulty, reduced speed and accuracy, omission of letters and numbers. Then they can have transposition problems of word, like now they can read as own. Then line skipping also, the poor page navigation, writing, drifting, and poor spacing. The spatial senses, that is orientation, the information needed to know where we are with respect to our environment. And that localization, the information needed to know where objects are with respect to the individual. So that can be oculocentric, that is eye based, and objects are referenced with the respect of to the fovea. And egocentric, that is body based, and objects are referred with the respect of the to the body. So this senses can also be hampered with the trauma in case of traumatic and acquired brain injury patients. And for this, they will be having difficulty to recognize where they are and the surrounding environment, and to judge the distance between the objects related to them or related to other objects. All these difficulties they may face. So three conditions are frequently associated with this problem, like hemianopia, that can be physiological. Then visual neglect. In this picture, we can see that the model is showing the full picture, but the patient who is having visual neglect problem, they are just ignoring one side of the image. So one part is visible to them and one part is not visible to them. Visual midline shift, that this is a type of medical condition that causes a visual and sensory shift in the concept of someone's bodily midline. Basically, the brain is unable to process the visual and spatial information properly, causing someone to feel as though his or her center of balance is shifted too far in one direction, causing serious problems with balance and motor function, making it difficult to coordinate movements and maintain central balance. Other symptoms include like constant sense of imbalance, problem with posture, abnormal changes in the sense of direction, and uneven weight distribution. This visual midline shift And then this vestibular dysfunction. The vestibular mismatch, visual vestibular mismatch, the central, which is central vestibular processing relies on input from the visual system. If the visual system is not accurately processing the movement and spatial information, the information it gives the vestibular system will result in a vestibular type symptoms. So that symptoms can include dizziness, nausea, balance problem, and all. The cognitive functions, in addition to the vision problems commonly associated with acute brain injury, cognitive, attention, language, memory, and emotional problems are common among acquired brain injury patients. The presence of such problems have a direct effect on the prognosis for active vision therapy. Because for treating acquired brain injury or traumatic brain injury, there can be some vision therapies also. So prior to considering the treatment plan for acquired brain injury patients, it is important to consider the patient's cognitive, attention, and language function, as well as his or her emotional state and motivation. So when we are coming for the evaluation part, we have 4 components for testing. Like the basic ocular examination we have to do. We have to perform oculomotor based examination and non-oculomotor examination, and some non-vision based tests. The other one, the previous slide. So the general test battery, that is the binocular vision assessment, is the cover test. We have to do cover test and AC by A ratio, and positive fusional vergence and negative fusional vergence. And we have to test step vergence and vergence facility test. We have to check the accommodative part also. Negative relative accommodation, positive relative accommodation, binocular accommodative facility, and monocular estimation method retinoscopy. The convergence amplitude, the near point of convergence we have to check. The sensory status, Watford dot test, and stereopsis testing. Then accommodative assessment, like monocular amplitude of accommodation, monocular accommodative facility, and NRA, PRA, and all this. So all these details I'm not going into. Oculomotor based test, we have to check the fixation, saccades, pursuit, and reading speed of the patients. And developmental eye movement test we have to do. The developmental eye, the other one, yeah, the developmental eye movement is there will be the letters arrangement for horizontal and vertical, and we have to check the ratio. So according with the ratio, we can check we can say it is normal, or it is having oculomotor dysfunction, or the patient is having oculomotor dysfunction, as well as read out the numbers and all. So all this will be diagnosed, or all this we could come to know with this developmental eye movement tests. And non-oculomotor vision based test, we have to check for confrontation, visual field, the visual neglect test. In this, like we can give this right-sided kind of picture, like some line will draw on a paper, and we'll give the patient to cut the line in the center. So the patient, if the patient is seeing the full paper, then they will go through all the lines and they will cut in the middle. But if the patient is not able, neglecting one side of the paper, then one side they will cut all the lines, other side they will just neglect it. Then we have to check for visual midline shift, then vestibular ocular reflex, dynamic visual acuity test, and color vision and pupils also. Non-vision based test, we have to know in details about the patient cognitive condition. Then if the patient is having any depression or irritability or fatigue or not, then speech, and physio and occupational intervention is going on, any physiotherapy the patient is going on, or any speech therapy or any occupational intervention is going on, and all that, and psychological counseling also. So yeah, so if we go for sequential management plan for the patient, we have to give optical correction for ametropia, and we have to give the lens power according to that. Then if the patient is having any diplopia or anything difficulty for reading, we may consider about giving prisms, then occlusion for diplopia, and then comes the vision therapy also. So the treatment plan, it's in details I cannot cover today. So just the overall idea I gave here. So to summarize the session, we can tell the visual dysfunction is extremely common in concussion and post-concussion syndrome. It is possible to screen for vestibular or oculomotor function expeditiously. It is important to document symptoms pre and post testing. Neuro-optometric rehabilitation can often help relieve symptoms in concussion and post-concussion patients. Thank you.
Thank you, Ms. Nandita, to give this nice presentation, this wonderful presentation. Actually, neuro-optometry is a very vast subject and complicated also, but you make it simple. And thank you for your time. We are short of time, so we'll just postpone our panel discussion after completing our next presentation by Mr. Arindam Mukherjee. He completed his bachelor in optometry in 2008 and completed his master's also in optometry. Currently, he is working as senior optometrist in Disha Eye Hospital in India, and his topic is spectacle troubleshooting. Screen is yours. Please proceed.
My screen is visible?
Yes, visible. Please carry on. Yes.
Okay. Good evening, everyone. First of all, I want to congratulate all the optometrists today in a occasion of World Optometry Day in all over the world, in UAE and in India as well. After a lot of studies, we are just, I'm going to discuss a small topic, a basic topic on spectacle troubleshooting and basic role of optometrists in it. Now, more or less, many of our optometrists have faced this kind of problems like angry patients and customers. In a busy clinic, they come and started screaming that I made a spectacle in your prescription and I am nothing able to see. I'm not seeing properly and it is not working. It's a very expensive. I'm not able to see anything. So we have to deal it carefully. But before come to the optometrist, they started in the busy outdoor in a OPT. Then first of all, the counter staff has to face the patient like this. They started to push each other to face the patient. Then acute manager comes into the scenario and he started to tell that politely that, yes sir, what is your problem? I will letting to you to the optometry room and he will finally able to sort out your problem. And the optometrist says, yes sir, I am here. I have the solution. I am here for solve your problem. In troubleshooting spectacles usually happens in due to remaining options like this, mainly due to optical error, due to patient adaptation problem, and due to refractive error, refraction error done by the optometrist also.
Hello, sorry to interrupt. Actually, you need to start the PPT mode. Actually, we can see only the first slide.
I'm already presenting in a PPT mode.
But you did not. You did the screen share. Left bottom. We can see only your first slide. It is not moving.
Is moving now?
Yes,
okay,
yes.
I stopped sharing. You click on screen share screen.
No.
Yeah, can you press enter and see if it is going to the next screen? No, it won't. It will not go. You have to close the PowerPoint presentation once again, completely stop the presentation. On your computer, you have to close the PowerPoint presentation and go to the Zoom and click on share screen. And once you click on share screen, you will see an option called screen on the left top but option. You have to select that and hit the share button. Right, now open the presentation. And it should work now.
Can you see now?
Yes, please go ahead.
Yes, yes, please proceed.
Still not working.
Can you press the keys on the left bottom corner? Can you see those arrow keys? And can you click on those? Left bottom of the screen. Okay, give me access. Perfect. Yep, it should work now.
Okay, thank you. Now, troubleshooting due to of spectacles happens mainly due to optical error, patient adaptation problem, and refraction error done by the optometrist or the refractionist. First of all, we have to go through a few checklists of the patient and his spectacles. We have to check the spectacle power according to prescription or not. That means in the spherical power or the cylindrical power or axis or the addition power is absolutely correct as per prescription or not through the help of lensometer. First, then the IPD, the interpupillary distance and optical center placement is absolutely okay or not. Then you have to find out, is there any prism prescribed or any unwanted prism which is not prescribed? Is there any spectacles or not? Pentascopic tilt is as per patient demand, because if he or she is wearing pentascopic tilt in his previous spectacles, you have to maintain the same angle in the new spectacles also. Otherwise, there will be a problem. Vertical imbalance and the other reels materials, sphericity and the tints and coatings, we also take it into the consideration before go through the next step. Now next we are going for the vision check with the spectacle made by the patient. If the vision is totally blurred or the clear but wavy or distorted or floor may seem like ocean. So for this, we have to check the visual acuity of the patient binocularly and monocularly, also the distance and near separately. Now the configuration test. We have to decrease the vertex distance. We have to increase the pentascopic tilt and increase the facial wrap or the facial fog. Now the troubleshooting fitting issues. If patient tells that he has seen a narrow reading area, that means we have to verify the fitting height and the PD measurement. We have to verify the addition power. And also add some pentascopic tilt and decrease the vertex distance to see the object clearly. If peripheral vision blurs and moves, we have to adjust the frame, like decrease the vertex distance to increase the facial wrap. If patient lifts head or glasses to read, then we have to assume that lenses are fitted too low. You have to adjust the frame to sit higher on the patient face and adjust the nose pad to closer together so that the frame sits higher on the nose, and also decrease the pentascopic tilt as well. If required, we have to refit the lens again. If patient lowers the head or the glasses to read at a distance, then lenses are fitted too high. Then we have to adjust the frame to sit lower on patient face. So for this, we have to lower the frames by widening the nose pads, increase the pentascopic tilt, and if needed, we have to refit the lens again. If patient moves reading material off to the side or better focus, then the PD is off or the lenses are not mounted correctly. We have to verify the monocular PD measurements and have lenses remade with correct PD measurements if required. If patient complains about the distance vision is slightly blurry, we have to increase the pentascopic tilt and decrease the fitting height as well. Usually, optical errors affects the patient satisfaction, practice success, and the decrease of confidence level of optometrists. Because if you see that 4 or 5 out of your 10 prescriptions are coming back with troubleshooting, then definitely your confidence will be lowering down. So we have to be careful during patient prescription. Finally, and after refraction recheck, we have to go for the previous glass of the patient first before final prescription. How much cylindrical power he is wearing or not, whether he is wearing a cylindrical power or not. Change of effective near power. If your distance power has been increased, if the patient is a hypermetrop, then near power also increase on distance power. The effective near power will be increased much. So the near reading area will come very much closer. That can affect a problem in troubleshooting. Then pentascopic tilt, like I talked earlier, that if pentascopic tilt patient wears in his old specs, then in new specs he also have to maintain the same angle to get the vertex distance as well. Size difference of the new frame and design of spectacles, whether he is wearing single vision frame, now he is switch over to bifocal or progressive. This kind of things you have to take into consideration before prescribing new glasses. And finally, you have to also compare the visual acuity with the new correction and old previous glass he is wearing before prescribing the prescription. And we have to also take in consideration of the profession of the patient, duration of professional work, how long he is working in front of either in front of computer, either he is a goldsmith. So you have to maintain the different working distance in different profession. You know that you habitual. This is what I am talking about. The habitual holding distance of near object. In we working in the computer for around 14-15 hours. He has to see the near object little further away from his eyes. But if he is a goldsmith or he's a have to hold the near object closer to his face. So we have to calculate the near addition power accordingly. He's now have to consider posturing his head or not during near work. Near object size he or she wants to see. And onset of using spectacle. Yeah, if he is using spectacle whole day or not. If he is wearing spectacle only for near work, that we have to also taken into consideration before prescribing. Finally, we have to make an angry patient with angry face to a smiling face. So for that, we have to attend the patient with a smile. We have to listen his problem actively. We have to behave politely, spend his sufficient time with the patient. Don't leave him unsatisfied. Assure him about your support and acknowledge him that the patient has made spectacle about you with your prescription as well. This is the main criteria for patient counseling is very, very important. Thank you. optometrist from UAE, Indian optometrist from UAE, for providing me such a chance to present in this auspicious occasion of World Optometry Day. And I also thank all of you to listen patiently in the short time presentation. And also I thank my all members of Disha Eye Hospital optometry team to stand beside me. Thank you so much. Thank you.
Thank you, Mr. Arindam. It's a very nice presentation. We know that refraction is the bread and butter of optometrist. So it's a very nice topic, though it's a basic one, but it's very nice. And thank you for your time. So for the next topic, I'll just want to request Mr. Oli to start the last topic of our session. Then we'll go for the panel because already it's late. It's very late night in India. It's 11:35, I think. So yeah. We'll start with Oli and then we'll conclude.
Thanks. Once again, thank you all for staying so late and attending the session. I'll try to keep myself as short as possible in terms of presenting so that we can complete in time. I'm sharing my screen to start the presentation. So I'll be talking on a topic which is more of neuro advances in amblyopia management, why we need so. So moving on to the next slide, we all know that amblyopia is defined as most of the time is unilateral, or sometime it's a bilateral reduction in vision when it is not attributing to any other lesions to the posterior visual pathway. So when everything is normal, still visual acuity is not improving, and there are some amyloidogenic factors which are giving complete clue, it's amblyopia diagnosed. Now, if you look at the prevalence, it is various studies shows 2 to 4% population, whether it's a kid or adult, people are affected, commonly unilateral in nature. And then the next 2 lines are very encouraging. If you look at the amblyopic patient, you can actually treat almost each and every one except the organic amblyopia or idiopathic amblyopia, where you do not get any cause for it. If you diagnose this in early childhood, then the treatment is far better in terms of the efficacy of developing both monocular and binocular vision. Having said that, even though if you diagnose them at a later stage of their life, still you can manage them. That's the summary of like amblyopia management, that you can manage at any age group. And why so? It's very important to understand the neurophysiology of it, as you know, again, to look at the visual system, what exactly happens in amblyopia. So what are the issues that puts the amyloidogenic factor together and have the visual deficits. So if you look at on this particular slides, that first order, second order, and third order, fourth order, fifth order neurons, if you look at all ranges of neuron, so first 3 are absolutely normal in amblyopia. What actually happens is in fourth order and fifth order, where you see a lot of changes happening. So if you look at lateral geniculate body, to start with, the cells are shrunken and then it becomes pale in nature. And this occurs in early deprivation of visual stimulation. So if you close the good eye, then the patient's vision starts again improving. So this is not atrophic in nature. So if you occlude the better eye, you get the improvement. So this suggests that one territory, like if you give a visual deprivation, the other eye will take that territory of the visual pathway and dominant over the eye, and leading to suppression of the eye which was having less stimulus or a deprivation of stimulus and resulting in amblyopia. However, this is not giving you what is the density of amblyopia is going to be, which can be explained in this particular slide, where in Brodmann area 17 and 4C, you will see a lot of, if you do a functional MRI, you will see that in ocular dominance column, the shrinkage of the stripes which are coming, visual stripes, that are getting affected. And that leads to expansion of the other eye or the better eye. Now, larger the expansion of the other eye, you will have more of dominant eye nature on that part, and you will have a lot of dense amblyopia. Now, why do we need a better treatment option in today's time, or why do we need a newer management option? Let's go through the traditional. All we know that traditional is patching, and we keep doing for all patients. However, residual amblyopia is one of the major concerns, followed by compliance. As you saw, that as the child becomes older and older, the compliance goes down. If somebody is more than 5 years, the compliance goes down by 50% by then itself. When it is younger adolescents and adult, they do not patch. So compliance is an issue. Then the time takes to improve visual acuity is very large. So it takes months, years times to treat an amblyopic patient. So it is slow improvement. And then after eliminating all these obstructions, you manage to give a good vision in the patient. But the moment you stop the treatment or stop patching of the dominant eye, the chances of recurrence is very high. And it is quite high. 1/4 of the patient actually starts showing deterioration. And moreover, in adult amblyopes, there are no such improvement that happens. Beyond this, what else we are missing? We're missing what happens to their binocular vision. God gifted us eyes, 2 eyes, so that we have binocular vision. It prevents a lot of accidents, injuries, it creates a better horizon of vision, it gives a better depth perception. Those all things are missing in our traditional approach. Hence, in today's time, amblyopia no more a monocular problem. It's recognized as a binocular issue, and all the newer treatment coming up in today's time, you will see everybody is talking about working both the eyes together. And let's see a couple of them. You must have heard about a newer modality called CureSight. So it is alternate to patching, as in what you do in a complete patching. It has a digital format, which is not obscuring the whole stimulus of the better eye. So you have a partial patching in the form of digital device, and it blurs the image of the fixating eye. So it is partial binocular approach, not truly a complete monocular treatment as you see in occlusion therapy. Now, if you have this kind of issues, because you are blurring the complete vision of that dominant eye, you may not get into a better amount of stereopsis. Let's see how this is being done. It's a very short and crisp video to explain how QRC works. So they have this red and blue filter. They have content onto the screen. So if you see, there are eye trackers available onto the device, and the child needs to, what they actually do is look at the content which are available already on Disney or Cartoon Network or some other places where they'll be observing them, and the system or the software will try to blur the dominant eye vision. So if you look at the right eye, the rabbit become that become blurred. So this is some mode of patching what they're doing. Moving to the next one, if you look at amblyopia, so it is combination of monocular and binocular activities. So try to go one step ahead and try to explore, can we combine both? Give monocular like a complete patching and also try to give binocular after a certain stage. Now, it is just opposite mechanism to work. At one point of time, you are saying, don't see anything from my good eye. And next time you're asking, try at least seeing something. So the mechanism of combining monocular plus binocular do not result in a better way. However, this is again software-based treatment, which can give you visual acuity, better improvement. So in this video, again, they are trying to explain that, yes, what we do over here is try to occlude or the blur the dominant eye, and under the environment of this dissociative goggles, which is red, blue in this nature, and child's place. So these are Tetris kind of games. You must have seen the blocks in childhood games. So everything child, what they do under the environment of red and blue target. Nice way to start with. There are multiple activities available. Child loves to play, but because it is combination of monocular and binocular, that makes it very, very inferior in nature, even lesser than the earlier product. Then what next? We have an option to treat completely both the eyes open. And that's why the Binocs treatment stands for. You can adjust the contrast of the dominant eye image. So here you're not occluding, not blurring the target. So the resolution acuity is intact. What you are doing is decreasing the contrast of the dominant eye. So let's see how the brain starts perceiving. So in a normal amblyopic eye, when you have a separation in nature, so if the right eye is seeing the red target and the left eye is blue, because right eye dominancy, brain sees only the red one. But if you reduce the contrast of the red, brain starts seeing the blue as well. So it creates the binocular vision. And why this happens? Because the interaction in the ocular dominance columns, which happens to inhibit the stimulus, goes off. So we have multiple activities in this based of dichoptic principle, and you can adjust the contrast over a period of time. As the visual acuity improves for the patient, the games become more challenging and the target size becomes smaller. You have multiple activities so that the adherence level or the engagement is there for the patient so that you get the results. Ultimately, at the end of the resolution acuity improvement, you can expect the vision, binocular vision also improving for this group of patients. So there are many publications coming up. These are the data which shows significant improvement in visual acuity only in like 6 weeks program. So you see the mean visual acuity, median visual acuity is improving by almost 4 logMAR lines in 6 weeks time. So it is very fast in improvement. And it is across for different age group as well as different kind of amblyopia. And the bonus for this treatment of any binocular approach is gain of stereopsis. So that is the ultimate glue which holds the vision, whichever improves in any kind of amblyopia treatment. Until unless you gain to the stereopsis level, the chances of recurrence into the amblyopia is very high. So gaining stereopsis is one of the most crucial part in amblyopia treatment. So I've seen this group of patients to have significant improvement in their stereo acuity. If you quickly look at the comparison, as I mentioned, that the one works on the principle of monocular approach, second one try to do combination of two, third one is a completely binocular in nature. And that's why the treatment is evolving. Everybody wish to try the best shot and try to improve the visual acuity of the patient. Ultimately, it is aimed to improve the patient visual acuity. But there are certain advantages of having binocular approach where you can improve their visual acuity, improve their fusion stereopsis, and a lot more beyond that, like a dependency on a hardware or a kind of device with a eye tracker, or to have a special device for the treatment is sometimes becomes very expensive for the patient to do. Whereas if the program can be fitted into any kind of laptop or desktop, that makes it a very effective tool. So these are the summaries of the comparison, how it shows, and we have seen no recurrence of amblyopia after binocular treatment and once you achieve the stereopsis. In terms of the efficacy in adults, again, binocular treatment, it defeats all other modalities which are available by a significant margin, because binocular neurons are active throughout our life. So when you approach a complete binocular way, you can get a better results with a binocular approach like Binocs. With this, I have to stop my presentation. I tried to make it as simple as possible. I would love to have question and answer session with our esteemed panelists next. Thank you once again, and congratulations once again on the World Optometry Day. Proud to be an optometrist. Thank you.
Thank you, Oli, for your nice presentation. It's wonderful and very informative. So we can start our panel discussion. I think few people are left, I think. So who are available? Mohammed Shuhel, you are available?
So you can unmute yourself, all of you.
Yeah.
So if you have any question, we can just start our discussion and we can conclude the session.
We'd love to hear from our panelists. If you have any question, please unmute yourself and then go ahead with your question. I'm trying to send invite to all the panelists and the speakers. And please go ahead.
The ROSK, yeah, thank you for your presentation, Mohammed. It was very good. It was really interesting. And just one question regarding this contact lens. What about this OCT in contact lens fitting practice nowadays? Because when we were practicing in Abu Dhabi NMC, we used to have this, we just for a, like OCT, anterior segment OCT for the checking the wall. So are we using still, for ROSK lenses these world, or is it useful, for fitting these lenses? And is anybody's practicing that kind of approach at the moment?
Thanks, Mohammed, for your question. I think our presenter is not here anymore. So however, we'll take this question up. Maybe I can share some insight. OCT does, anterior segment OCT does play a significant role, especially the wall, checking the thickness on all aspects. You can check the clearance, or you can check the landing zone, how much area or expected fluorescent area or the gap you want to have. I think in that respect, apart from doing your mapping of the cornea or customization of different kind of ROSK lenses, especially ROSK is known for customization on asymmetric design. So anterior segment OCT does play an important role. It's a luxury to have in a clinical practice anterior segment OCT for this specialty contact lens. Maybe we'll have the inputs from the speaker as well and send you the answer.
Do you think that this will replace our traditional method of staining? Is there anything like that? Because we will have a clear-cut idea what is the relation to the cornea or the posterior side of the lens. So do you think that if there a lot of studies has to be done, to conclude something that this is the standard fitting criteria or something like that we see in the future? Because I think we are not taking that as a serious thing, because we are still relying on the traditional method. I'm not saying the traditional method, I don't know is the right word to use it, but still, so this one, I have done a couple of things, just seeing that when I was in NMC. Now, what do you think the future of that one? Because I do understand that it's a luxury for having to incorporate in a clinical in a hospital setup. It's easy, but for the private practices, like as an optical clinic or something, it is kind of sometimes might not be possible, most of them. So, what do you think about that?
Again, the machine never replaces your clinical assessment part, or whatever machine or the software you may reinvent. Clinical assessment or traditional with a stain and slit lamp examination is going to be there, because how you see on a clinical perspective or a clinician point of view is more accurate than a simulation. The OCT machine do not give you the actual one. They simulate from the reflection. So sometimes it may go wrong. I'm not saying that it is going to be in a wrong way, but the actual clearance, or maybe whether some point of time, whether you are having a very tight landing zone, I think those things can never be replaced with the OCT machine. It's always a traditional staining and a slit lamp examination makes a better clinician. At the same time, not everybody can afford to have anterior segment OCT in the clinical practice.
Okay, thank you.
Any other question for other speaker? I think we can finish the session. We can conclude. I would like to special thanks to Mohammed Oli for this event. Without you, it is not possible. And for all the speaker and all the panelists, I would like to give immense thanks for your time, and it's very nice presentation. And it's World Optometry Day. So next year we'll make it big, and we'll make it in a different way. hopefully.
Thanks. It's a pleasure to have every one of you on a special occasion. Good night.
Thank you.
Okay.
Thank you.
Good night.